Hello everybody and welcome to January's edition of the IMV Imaging Journal Club with myself. My name's Amy, I'm one of the vets at IMV Imaging, and today I'm going to be discussing a paper which examines using ultrasonography to quantitatively evaluate both acute and chronic renal disease using the renal cortical thickness to aorta ratio in dogs. So just in case this is your first time at the IMV Imaging Journal Club, the clinical team here at IMV Imaging will do these monthly, where we have a look at a recent and relevant paper and try and make it relevant for first opinion practitioners as well. And then the Journal Club is available for a whole month on demand, and you get the CPT certificate for viewing. We would really love you to get involved with the discussion, so feel free to put any questions in the Q&A box on the webinar platform, or you can send any comments, questions or queries to our inbox, which is clinical@imv-imaging.com. So the paper that I'm going to be looking at today is by Chu et al., done in South Korea. And it is examining the ultrasonographic quantitative evaluation of dogs with acute and chronic renal disease by examining the thickness of the renal cortex and indexing it to the aorta in dogs. And this was published in Veterinary Radiology and Ultrasound in 2022. So it is a new study. The reason I wanted to examine this particular paper is that it is relevant for first opinion practice, especially ultrasonographers and first opinion. It's clinically a common issue, and most, if not all, practices will have equipment that is capable of performing this sort of an exam. And for those of you with an interest in abdominal ultrasonography, you'll know that canine patients are lacking reference ranges for kidney measurements, which can be used any more usefully than really just for sort of tracking and monitoring individual patients. So when we are assessing the degree of kidney damage, in acute kidney injury, the kidneys, especially structures in the cortex, are very prone to ischemic and toxic damage, which leads to metabolic and structural changes within renal tubular cells, which causes swelling of the renal cortex with inflammatory infiltrate, which can lead to irreversible or reversible damage. And this generally does lead to a larger cortex on ultrasonography. Whereas with chronic kidney disease, you end up with renal cortical atrophy, glomerulosclerosis, and fibrosis, which is caused by chronic inflammation, and you therefore end up with a progressive loss of functioning nephrons. And as such, you will have a smaller renal cortex. So, as we all remember, and is a frustration in general practice, elevations in the biochemical parameters associated with kidney disease in chronic kidney failure, such as your blood urea nitrogen, creatinine, SDMA, and electrolytes, calcium, phosphate, and potassium. They only occur after a significant proportion of functioning kidney is lost, 2/3 in the case of BUN and creatinine. And abdominal ultrasound findings are subjective and not quantitative in this regard. So things that we're looking out for in a subjective fashion in chronic kidney disease when we're examining kidneys is an irregular kidney contour, a smaller kidney size, increased cortical echogenicity, and an abnormal corticomedullary junction, whether that's positionally, lack of symmetrical shape, change in echogenicity between the two, and pyelectasia as well, which is dilation of the renal pelvis. So other ways of assessing the damage, for instance, with ultrasonography and glomerular filtration rate. Renal length and renal volume have been shown to be significantly correlated with estimated glomerular filtration rate in people. However, it has also been shown that the renal cortical thickness better correlates with the estimated GFR than the renal length and volume. This is because kidneys will have sinus fat within them, which means that the renal length and volume can be quite changeable and not particularly accurately related to GFR. Furthermore, evaluation of the renal cortex is very useful because the glomeruli, which act as the actual filtration barrier, are distributed in the cortex, whereas as a functional unit, whereas the primary function of the medulla is actually to maintain urine concentration. And the medulla has actually been shown to grow in response to cortical thinning to help to maintain urine concentration. So we are looking at the renal cortical thickness reference range in dogs is 3 to 8 millimeters, and the canine renal length to aorta ratio is 5.5 to 9.1, which are quite broad reference ranges. And these ranges are too wide to be used to actually evaluate renal pathology, especially quantitatively. And of course, the highlight of being in veterinary is that we have the breed effect. So rather than just one human, we have a whole range of dogs with different shaped kidneys. So recently, a renal cortical thickness reference range has been developed, which does factor in both body weight and body condition score, which is sort of the silver bullet, really, when we think about our patient population. And in this study, which these authors were involved with, the renal cortical thickness to aorta ratio has been shown to be constant regardless of body condition score and body weight, which is fab. So that kind of sets us up to do this next study, which I'm focusing on here, which is really the next step. So the objectives of this study, first of all, were to determine if there is a significant difference between the actual renal cortical thickness and predicted renal cortical thickness, considering body weight and body condition score, in dogs with both chronic kidney disease and acute kidney injury. Secondly, they wanted to assess the usefulness of the renal cortical thickness to aorta ratio as a quantitative index to reflect kidney pathology in chronic kidney disease and acute kidney injury dogs. A quantitative index would be perfect and does fill quite a sort of gap in our reference range interval for kidney disease at the moment. The hypotheses of the study were that the renal cortical thickness in dogs with chronic kidney disease and acute kidney disease will be outside of the normal ranges. And secondly, that the cortex to aorta ratio will be smaller in chronic kidney disease dogs and larger in acute kidney disease dogs than in normal dogs. So the equation there is the equation that they've used to calculate the renal cortical thickness in millimeters, which factors in both the body weight and body condition score, and that will come into play a little bit later. So this was a multi-center with 4 hospitals, retrospective analytical design with cases harvested from 2019 to 2021. Based on review of hospital records, dogs were categorized as either being in chronic kidney failure, acute kidney failure, or normal. So your criteria to be classed as being in chronic kidney failure is a clinical diagnosis of chronic kidney disease via IRIS guidelines using blood urea nitrogen, creatinine, and SDMA, plus analysis of proteinuria, low specific gravity, and the ultrasonic abnormalities that you may discover on abdominal ultrasound of these patients. Acute kidney disease or acute kidney injury criteria were an acute onset of azotemia with a known pre-renal, renal, or post-renal cause of the acute kidney injury. Animals were excluded based on missing lab tests, missing components of the abdominal ultrasound, or there being greater than 1 week between the laboratory tests and the abdominal ultrasound. And normal dogs were recruited, their records were recruited from the previous study that this team had done, which I referenced on a previous slide. So how do we take these ultrasound pictures? The renal cortical thickness is performed in a mid-sagittal plane. So these dogs were imaged in dorsal recumbency. And the measurement is taken from the leading edge of the center of the base of the renal pyramid to the trailing edge of the renal capsule at 3 different points on each kidney. And then an average is taken for each kidney, both left and right, and that is shown by the white arrows in section A. The aorta is measured in systole as the maximal luminal diameter just caudal to the left renal artery, shown by the white asterisk, in the sagittal plane, again imaged in dorsal recumbency. So quite straightforward, easily applicable measurements, which always helps with these things. Okay, signalment. So 578 dogs were reviewed and 524 were excluded. So this was probably a bit of a labour of love. Only 54 dogs remained, 45 with chronic renal disease and 9 with acute. And the 30 dogs as normal references were from another study. So unsurprisingly, the most common laboratory findings were an elevated BUN and creatinine, elevated phosphate, and a reduced urine-specific gravity. Very much the most common finding, actually. The most common clinical signs, we've got anorexia, lethargy, and vomiting. So actually things like weight loss and PUPD were not mentioned on that section. So the mean body condition score of the affected dogs was 4 and normal dogs 5, but we do have a sort of heavier range in normal dogs and a lighter range in the affected dogs, which is not unsurprising given that dogs with renal failure are often quite skinny. The mean body weight of the affected dogs was unsurprisingly again lower than the normal dogs, given our poor body condition score of affected dogs plus chronic kidney disease dogs are usually smaller. And then mean age of affected dogs, the affected dogs are generally older. Again, normal dogs are younger. So I do feel this is something that potentially could be altered if you're looking for a more sort of normalized population that potentially matches the study populations. We could potentially have some older normal dogs, but then again, dogs in acute kidney failure do tend to be on the, in chronic kidney failure do tend to be on the older side. So the first of the results graphs, so just to explain what's going on here, the black line, the black dots represent the predicted renal cortical thicknesses using the equation below, which is the equation they had got together from their previous study. And the renal cortical thickness in millimeters is shown on the y-axis. So our red dots are animals in acute kidney failure, and our blue dots are animals with chronic kidney failure. So as you can see, the acute kidney injury dogs are generally have a higher renal cortical thickness than predicted, and that black line is predictions. And the chronic renal failure dogs have a smaller cortical thickness than a predicted normal. So the green stars are kidneys which have undergone compensatory hypertrophy, and I will explain that later. It's just to show that they are outliers in a sense. So I really like that graph. It's some solid data, and you can really see the correlations quite nicely. Secondly, one of their questions, can the renal cortical thickness to aorta ratio actually be used quantitatively? So looking at the results here, you can see that there's a really lovely correlation between the ratio of the cortex to the aorta and the type of kidney failure that the animal is in. And this has is statistically significant at p equals less than 0.05. So we have a difference between normal and chronic, normal and acute, and also between chronic and acute. So that is very clear, which is good to see. Secondly, and I really like this graph as well, because they've actually broken down the chronic kidney disease candidates or patients into their iris staging. So as you can see, the renal cortical thickness to aorta ratio actually decreases the further through the iris staging that you go, which is a really good correlation to see and implies that there is a really strong correlation there. And equally, you can also see on the right-hand side, the acute kidney injury group very starkly have a higher renal cortical thickness to aorta ratio. And all findings in this case were statistically significant to at least a significance of p equals less than 0.05. Predictably, I suppose, the numbers of dogs in each iris stage, we had more dogs in the earlier iris stage, 18 for first iris stage 1, and we only had 5 dogs for iris stage 4. And remember that the acute kidney injury group was only 9 dogs. But yeah, I really like the visual representation of this data. I think it's really, really good. So we all like reference ranges and we all like intervals. So in order to decide a cutoff value of the ratio of cortex to aorta, an ROC, or receiver operating characteristic curve analysis, was performed to decide the optimal cutoff for each ratio to discriminate between normal dogs and chronic kidney disease dogs and normal dogs and acute kidney injury dogs. And sensitivity and specificity for each cutoff has been decided. So for chronic kidney disease, if you apply a cutoff of the cortical thickness to aorta ratio of up to 0.6, your sensitivity, so the chances of having a false negative in this case are 10%. Your sensitivity is 90%, which is good, and your specificity, so your chances of false positives, are 78%. Acute kidney injury cutoff ratio of 0.79, the sensitivity and specificity are really good in this case, at 92 for sensitivity and 95 for specificity. So given that this is a sort of new finding, a new area of work, there's some fairly decent cutoff reference intervals here which could be applied to practice, which is good. Now, given that we are dealing, first of all, with animals and also diagnostic imaging, there are always going to be outliers, and specifically so the case with renal imaging, because each dog has 2 kidneys, so it gives you sort of a greater scope for strange results to come up. So just to discuss these, 2 dogs in the study actually developed acute on chronic kidney disease, which is another thing that we do see commonly in practice and can diagnostically be challenging. So for these dogs, the ratio was higher than would be expected for their iris stage. So with their iris stage in chronic renal failure, the ratio is going to be low, but with the acute onset on top, the ratio was actually sort of higher than that. And that landed these dogs in sort of middle of the range to slightly above normal. So that's something to bear in mind if you're ever working up these sorts of cases and you're wondering, you've got classic signs of acute kidney injury, but your ratio is not as high as you might expect. It could be because there's actually underlying chronic renal disease. So these cases are quite diagnostically difficult. And for these patients, one of them developed urethral obstruction and one developed pyelonephritis. In 2 dogs in this study, coming to discuss the compensatory hypertrophy section, one kidney had a very small cortex to aorta ratio, and the other kidney had a very large cortex to aorta ratio. So first dog had elevated BUN and normal serum creatinine, so did not feature on the iris staging. The small kidney had a very small ratio and the large kidney had a very large ratio. Dog 2, similar picture, but had elevated BUN and serum creatinine, so was staged at iris level 2. And again, a very big difference between the cortex to aorta ratio in the small kidney to the large kidney. And this is where you will see compensatory hypertrophy come into play, and these dogs are outliers. So this particular section is interesting. A hyperechoic layer was observed under a relatively hypoechoic cortex in some individuals. The paper did not state if these individuals were in the chronic renal disease, acute kidney disease, or normal category, so didn't expand on which patients were affected by this. This hyperechoic layer underneath the cortex led to confusion over where the measurement of cortical thickness should be made. Now, it should be noted that the paper did not actually point out where this cortical thickness was. So in the diagram to the right, I have used a yellow arrow and a yellow asterisk and a green asterisk to point out what I think they may be referring to. And I do think that it's more likely to be the yellow asterisk that they are referring to. So on examining the kidney in question with colour Doppler, the hyperechoic renal parenchyma that they are talking about, so potentially green asterisk or yellow asterisk, was located towards the cortical side of the arcuate arteries. The arcuate arteries in this diagram, in this picture, are showing up in red between the renal medullary pyramids. So the arcuate arteries mark the boundary between cortex and medulla. So based on colour Doppler assessment of this kidney, it was decided that the hyperechoic renal parenchyma was a cortical structure and therefore needs to be taken into account when making these measurements. So what I like, again, about this paper is that the authors wanted to do more with this finding because we don't want any doubt to be included in our reference ranges. We want them to be as useful as possible. So they went to a cadaver lab and imaged canine kidneys in cadavers until they found kidneys which had the hyperechoic layer as they had identified in the in vivo specimens. Again, the image A is a picture of a cadaver kidney, and they did not point out which layer they were referring to as being their layer of concern. So again, I've highlighted what I think they're referring to with a yellow asterisk as being the hyperechoic section below the cortex, which may or may not be cortical. Now, I've highlighted the arcuate arteries with blue asterisks just to show you that these structures are sort of at the same level. They then took this kidney in question and histologically stained it, and this is in image B on the right-hand side. And histological evaluation showed that this hyperechoic layer, which may or may not be cortical, was occupied by the juxtamedullary cortex, which is shown by the double-headed arrow on the right. And this is on the cortical side of the arcuate artery, shown with the solid arrow on the right. So when comparing the ultrasound image with the histological section, the hyperechoic layer of the renal parenchyma was interpreted to definitely be renal cortex. So to discuss this paper, hypotheses, both of them were supported, which is great. The cortical thicknesses of chronic kidney disease and acute kidney disease patients, when factoring in their body weight and body condition score, are outside of normal ranges or outside of normal calculations for what they should be based on previous work done by this group. The cortex to aorta ratio is smaller in chronic kidney disease patients and larger in acute kidney disease patients than in normal dogs, which is great and useful for us in practice. So the renal cortical thickness deviates from normal according to the disease process in the kidney. So in chronic renal failure, it will decrease due to cortical atrophy, glomerulosclerosis and fibrosis caused by chronic inflammation. But in acute kidney injury, we've got to remember that the cortical thickness will increase due to cellular damage and structural changes, which causes a change in tubular cells, leading to inflammation and increased vascular permeability, a decreased endothelial cell integrity, leading to cortical edema. So, the renal cortical thickness to aorta ratio can be used as a useful quantitative index to evaluate renal pathology with other typical ultrasonography findings. And this is useful because you could potentially use this before biochemical changes occur. And that sort of intervention does actually really change the workup of kidney disease patients, particularly in chronic renal failure. Acute on chronic kidney disease can be very hard to differentiate from acute kidney injury just on its own. So 2 patients in the study had their ratio, the 2 patients which suffered from acute on chronic onset, their ratio was similar to or slightly higher than normal dogs, whereas beforehand their cortical thickness to aorta ratio actually matched their iris stage. So bear in mind that acute on chronic kidney disease will increase the renal cortical thickness, but not as much as you may expect if it was purely just an acute onset. And in human studies, it has been shown that compensatory hypertrophy does occur in a contralateral kidney, and the degree of compensatory hypertrophy is proportionate to the parenchymal reduction in the damaged kidney. And this will therefore normalize glomerular filtration rate for that patient. So blood biochemistry may well be normal. However, these compensations actually could well contribute to glomerular or tubular injury and hypertension later in life. And these hypertrophied kidneys are actually quite vulnerable. So it's useful to know that dogs with large differences in renal cortical thickness between their kidneys merit close monitoring, certainly with ultrasonography and biochemical testing. So the paper really did focus quite heavily on these sort of 2 zones of the renal cortex, or having a hyperechoic deeper parenchyma. So it's disappointing to me that the area in question was not highlighted. But they did mention that in pediatric ultrasonography, the renal cortex can be divided into 2 zones. However, a previous veterinary study has actually shown that the phenomenon of hyperechoic parenchyma deep to a hypoechoic renal cortex was actually outer medulla, and that this outer medulla was an incidental finding in dogs. So this is completely at odds to what has been found in this study. In the discussion, they pointed out that the cadaver image, so there'll be no Doppler applicable to this image, showed that the hyperechoic outer medulla, or potential cortex, was actually appeared to be deep to the arcuate artery. But then on histology, and it would have been the case with Doppler in vivo in the dogs that were alive at scanning, showed the structure to be on the cortical side of the arcuate artery. So I don't think it's been any further clarified, and potentially it wasn't something that could be clarified, but if anything, the discussion section actually muddied the waters a little bit more. So limitations of this study, and this is so often the case, is that we have a small sample size and patient number, and the authors did point out that this could have affected statistical application, particularly with the acute kidney disease group, and there were only 9 of those. And you will recall that the ROC cutoffs to determine cutoff values for the cortex to aorta ratio, the sensitivity and specificity for the acute renal failure group was actually really, really good, sort of surprisingly so given the small sample size. So I think that needs to be borne in mind. Sadly, having examined nearly 600 clinical records and only being able to get 54 patients, it tends to suggest that a lot of the ultrasonographic exams were probably not taking cine loops of both kidneys, in sagittal plane, and the aorta through systole and diastole as well, which I suppose is not altogether unsurprising. But if you listen to our last month's journal club, where Sam examined the ACVR and ECVDI consensus statement for standardization of abdominal ultrasound examination, taking cine loops during your examination is strongly recommended. And I think it probably will help to open doors to do further studies of this kind, where images and videos are reviewed, and the particular plane of section and stage of cycle that you want, you can get, and you can analyze the images. So I think just bear that in mind whenever you are performing abdominal ultrasound exams. Not all of the iris stages had SDMA figures attached to them, which again is not unsurprising, because the iris staging had SDMA incorporated only fairly recently. And of course, no iris stagings had glomerular filtration rate attributed to them, but again, that's almost sort of expected. Again, it's not really feasible, especially in a retrospective study. And blood pressure wasn't mentioned at any point with regards to iris staging, whereas proteinuria and urine-specific gravity were. But again, I don't think that's particularly relevant for this study. A more accurate assessment would have been possible if the patient's glomerular filtration rate were compared to the cortex to aorta ratio. But again, as I say, not feasible retrospectively, but could be a really good area to look at to bolster these new reference ranges and cutoff, to use these cutoffs actually quantitatively, which would really change things. And obviously the gold standard here would be to use histopathology as a reference, but again, not really ethically sound. The labeling of the ultrasound images was lacking, which was upsetting because it was quite an interesting point to look into. And again, the normal dogs were larger in terms of body weight and had a higher body condition score and were generally younger. So that is not unexpected, given that dogs suffering from chronic kidney disease are generally smaller dogs who are thinner and older. But I think it would have been interesting to have a normal population of dogs, normal in inverted commas, who were potentially better matched for the chronic kidney disease patients, and the acute ones as well. But it's unknown how significant that is as a factor. But having said that, the paper did obviously point out that your renal cortical thickness to aorta ratio is constant regardless of body weight and body condition score. So potentially not relevant at all. So that's it from us. Thank you so much for tuning in. I hope you found that useful. And I've really enjoyed getting to the bottom of getting hold of another useful measurement that we can use in general practice in our ultrasonography exams. So again, if you have a question, please do email us on clinical@imv-imaging.com or stick it in the Q&A box. And we look forward to seeing you again at another journal club soon.